I am so excited for today's guest. I have wanted to do a segment about addictions and OCD for a long time. I needed to find my person, and she's here with me today. So, Thea Wessel, who I'd like to introduce, is an LPC licensed professional counselor as well as an LAC, a licensed addiction counselor in our state, Colorado. She's also nationally certified as a master addictions counselor and has other aspects of her professional world that include some holistic intervention. So, as a wellness collective, we love to see that you are also utilizing other methodologies in your work and are also a doctoral candidate at the California Institute of Integral Studies. So, very excited to be talking to you. Having worked for 15 years in mental health and substance use treatment, I believe that you must have a lot of wisdom to share with our listeners, and also a lot of expertise to share with me, as I am strictly an OCD clinician and have a lot to learn from addiction specialists. So, welcome, Thea.
Thank you.
So, we're just going to jump right in and say, we both know, you and I, that there is a co-occurrence of our two specialties.
Yeah.
However, there is not, as far as I know, a lot of collaboration between the substance use world and the OCD world, or not as much as I think would be helpful for our clients. So, just to give our listeners the facts, according to the Journal of Anxiety Disorders, over a quarter of individuals needing OCD care also have a substance use disorder. So, in your opinion, Thea, when both disorders are activated, what should we treat first?
I think that's a tricky one in mental health, just generally with compulsive patterns of use and substance use, in that we used to say we treat one and then the other, and it was first mental health and then substance use, or substance use and then mental health. And I think now we're at a place that as we start to realize that these disorders aren't really as unique as we've kind of looked at them, that we have to start saying is, what does it mean to have providers that can have a diverse kind of experience, or at least an ability to say, how is one of these things like the other, even if it shows
Yes.
different.
Yes. Beautifully put, that we're trained to kind of be black and white and say, like, first treat the depression, then treat the addiction, or however it is that we happen to have been trained. And then we get the client in front of us, and it's so much more complex than that.
Yeah. And they're fighting each other, right? So if you don't have someone that can work with both, then we end up with multiple providers who might have different theories, different ways that they look at it. And now we have the client potentially in a conflict of trying to make sense of what's really plaguing their lives in a way that they're kind of stuck if we're not careful.
Absolutely. So, for our listeners, let me just give one example of the
Sure.
way an addictions provider and an OCD provider might be giving a client different messages. So,
Mhm.
in OCD, we work on something called moral contamination, where we don't want people to avoid something that makes them uncomfortable or a situation that makes them uncomfortable. So, some of our clients have a moral contamination fear around being in a bar or being around alcohol once they're sober. However, we find ourselves in sort of the tricky position of encouraging and, in fact, putting on a fear hierarchy, being around alcohol, touching alcohol, having alcohol like in the home, and
Sure.
also knowing that like you can trust yourself if you want to make the choice not to have the alcohol, you can trust yourself around it. Whereas that's the OCD world, that's the strict OCD version, which of course might not align with addictions counseling.
Well, it doesn't align if you take an abstinence-based perspective, right?
Mm-hmm.
If you looked at something like a compulsive disorder and exposure therapy, it would actually align significantly,
Yeah.
right? And I think even originally saying is like, how are some of these things different? I actually think they're very similar, right?
Mm,
There are rituals around substance use,
yes.
which is often some of the parts that make it really difficult for people to quit that behavior. And so kind of what do I mean by that? So, right, my substance of choice is coffee. And when I wanted to quit caffeine, tea doesn't give me enough of the ritual to then
Yeah,
change what's in my cup. But
right.
when I started working with something like mud water, where I could froth it and put in cream and I had the whole experience, what I realized is it really wasn't always about what was in my cup. It was the ritual of like, this is how I start my day. I take
Yeah.
my big deep breath. I kind of go, what do I have to do today? I start my plan. And so I think when you look at discomfort and the inability to manage discomfort, they're very similar. And really both are now under, even though they're looked at differently, compulsive
Mhm.
disorders.
Yes.
Right, because it's this need to do it, even though
Hmm.
I know intellectually in head that it's not keeping it or doing something for me that I want, but I'm so afraid of doing anything different that then I don't even realize that fear is driving everything I'm doing. And fear
Mm.
is, I think it's a weapon of the darkness.
Mhm.
Absolutely, when it's driving the bus is where people will suffer because fear will keep us from living
Mm,
in
brilliant.
incapacity. Yeah.
Yeah, brilliant. You just surprised me. I didn't realize that we would be so aligned. And so that's why it's like such a joy to have on a provider that's not an OCD clinician, but actually aligns with a lot of our philosophy as therapists. So, um, I have a poster in my room that says, "What stands in the way becomes the way." That pushing through our fear, pushing through our darkness is how we get to the other side. So let me just make sure I understand you clearly in your philosophy. So you do not espouse an abstinence based um, addictions recovery, or it's sometimes.
So, well, what's hard is people don't often even know the history, even providers, about where an absence base comes from, which comes from a temperance model, which is a
Mhm.
historical model of saying no use is safe use. But if we look
Got it.
at the data, a majority of people who use substances, all of them, cocaine, heroin, alcohol, caffeine, nicotine, 85% of them don't actually have a diagnosable problem.
Wow.
So majority of people are using successfully, then we need to have that different questions about what's unique about that 10%. But I think
Mm.
similarly, right, is in a Western culture perspective, we say, let's take something super complex and try to make it really simple and see how that applies to everyone. And
Mhm.
it's kind of like, well, for some people, abstinence is their path because they
Mhm.
don't want to box the demons. And for
Yeah.
other people, it's not because they want to box the demons and then be able to say, what does that look like? And now we say recovery is really, there's many, many pathways. And so you might have someone who says, look, I don't play with opioids. I like them too much, right? But I
Mm.
have a successful relationship with cannabis or alcohol. Where now
Mm.
when we look at how we've changed diagnostic, it's per substance because people don't have compulsions for every substance that they use. And
Mhm.
what we know is the more the substance met the need, the more you used it, the more likely you're going to get to that being that automatic pattern of compulsion that now it happens without thought. And
Mm.
drugs and alcohol work 100% of the time.
Mm.
So it's negotiating that space to say, well, where are people at? So the spectrum is not often looked at. We just say there's no such thing as successful use, even though a majority of people are.
Oh my gosh. I am learning so much just in a few moments with you, Thea. Um, so you've already answered my next question, but I'm going to go ahead and ask it again more specifically. What are some of the behaviors and addictions that resemble that of OCD?
I think the ritual perspective,
Yeah.
right? So when you control for the substance, you still have people that need it. When we control for the chemicals, or you put people on drugs that look like those, still have this. And really, I'm transpersonal at this point and very existential, is I think that all peoples have traditions to ritual, right?
Mhm.
That was the way before we went intellectual. And I think there's a craving for that, that we're
Mm.
addressing in things that can fulfill the need rather than working through like what's making me uncomfortable about the fact that like Western culture has no rituals. We have no transitions from being a child to adult. We used to have one ritual, which was sitting down at dinner as a family. we lost that ritual in a lot of ways in many, many homes, that I
Mhm.
think it's just so complex to look at why are people hurting the way that they are?
Yeah.
And what are all the different ways and tools that they're using to manage their suffering? And I
Mm.
think in your model, like you're saying, right, is we have a compulsion to suffer.
Mhm.
Pain is inevitable, but if we won't walk through that pain and find the gift in the wound, we suffer. And
Mm.
that is so comfortable for people now that we all
Mm.
find ways to take the edge off.
Yeah.
Alcoholics, I think, lose the same things as people who have compulsions for substance use, but
Mhm.
it's a socially acceptable compulsion. Nobody's like, you work too much, right? It's like,
Mhm.
car, get the big house and you'll be happy.
Mhm.
And then I have people who've done all that and they're like, but I'm not happy.
Mhm.
And even teaching happiness as an endpoint, like you're going to get there and then that's where you are. I'm like, happiness isn't an endpoint. It's
No.
that you want life to be more balanced, right?
Yes.
That the fluxes aren't so big, that I'm suffering so much that I need such a big release, that it's like there's this balance in just being able to say both of these things are part of the experience.
Mm.
And how do you open to them, walk through them in a way that gives even the darkest parts, substance use, OCD, right? These, and please correct me if I'm wrong, OCD is not my expertise. There's shame in it. There's so
Yes.
much shame in it because the head knows, the heart doesn't. So
Mm.
really what's boxing in someone is the difference between what their head and their heart need. And in
Mm.
a culture that says you just outthink the heart, people don't even have language any longer to talk about the emotions that are there, or the pain, or the fears and worries. They just go, pull up my bootstraps, keep trucking, what I'm
Mm.
supposed to do. And I'm like, that's suffering, because
Mhm.
they'll just get louder and bigger because they're supposed to tell you something about you and you're not listening.
Mm. Wow. I love how you said that. On so many levels, I am so incredibly aligned with what you're saying. So one other kind of well-known concurrence between our two strategies is that both OCD work and addictions work necessitate a family approach.
Yep.
Can you explain why a family approach is necessary in addictions? We know this, but
Yep.
I want to really know from your perspective.
I'm going to kind of say it more metaphorically than kind of in
Mhm.
traditional languages, in that if you have a poisoned forest,
Mm.
you take out a tree and you treat it and you teach it things, right? And then you put the tree back into the poisoned forest, what happens to the tree? So we have to be looking at what happens, because these are not usually individual kind of disorders, right? They
Mhm.
came from spaces. Who taught you about emotions? Who taught you how to deal with those things? How did they teach you how to manage that stuff? That it gets really complex. And we live in a world, Western world at least, that says, I would be fine if you stop doing it. So
Mm.
you stop doing it. So it's easier to say, we would be okay. So like when I work with couples and there's substance use involved, and they're like, we would be doing great if this person wasn't using. And I'm like, no, you wouldn't. Like there's
Mhm.
a lot more stuff under there, but that's the illusion we want to create. And
Right.
so with families, it's the accountability, right? But
Right.
I think the challenge is saying we're all doing the best that we know how. And even
Yes.
as parents, we're doing the best that we know how.
Mm.
And sometimes as a parent, we have to own that our choices affected our kids in a ways that we didn't intend.
Mm.
There's a joint accountability to say our relationships are bidirectional. You influence
Yes.
me and I influence you.
Mhm.
And that is important to help people get out of it's my fault, right? Because that's a
Yes.
shame-based, paralyzing emotional state that then people can't work through, to being able to say like, okay, what I do is not who I am.
Mm. Mm. Completely agree. In the world of OCD, I would say that a lot happens to be toxic niceness. And so I like that term, because the kinder thing to do in an OCD family system isn't necessarily the nice thing to do in the moment. So we have family systems that are participating in compulsions, who are enabling somebody to stay stuck because they love them. It's coming from the most positive place. But
But positive is in that you want to fix someone's pain.
Yes.
Right? Like there's an altruistic piece of that. Until we accept that you can't fix someone's pain,
Yes.
right? Which is, I think, in a lot of ways why people come to therapy. We get trained to understand that those are instinctual responses and to not react to them, to be able to sit in the conflict, to be able to say, well, what are you doing? And what do you believe that doesn't go in line with each other? And then they are making people uncomfortable. So when I have a ritual in my OCD, I have a ritual in my use, it's a quick fix. Because it's still that illusion that how I'm feeling is wrong. That real space of then saying, you know what, nobody taught you this. This actually, I think the cultural wound around emotion is intergenerational now. That many people, when I do my therapy work, I'll look at them and I'll be like, it's actually a foreign language now. To be like, I have pain. And we complicate things as human beings, I would argue. And so we have these emotion charts of like 100 emotions. And it's like, that's overwhelming to anyone, which really, when we look at emotions, there are 6 basic ones, maybe 8, if you look at different research. And everything else is like, right, those are the primary colors. And everything else is like a blending to something else. Like frustration is a pink version of anger, which is red.
Yep.
But if you still can't say, I'm angry, or I hurt, or I have anxiety, which I think is a synonym for fear, which again, we're not even asking people to say, I'm afraid. How do I deal with fear when I can't even say the word and I use a synonym because that feels more comfortable? I don't have to explain to you that I'm afraid.
Right.
Yeah, go ahead.
No. I mean, I love that so much. And the concept of, we say like, I have anxiety. I actually encourage my clients to reframe that and say, I fear, fill in the blank, right? To very much own what is the core fear. If you're my client, you hear me ask that all of the time. And people often have to pause. Sometimes we have to journal to get to the core fear because it's not obvious, because we're in such a response cycle with the feeling of being anxious. Again, I agree with you. It's not really a feeling, it's a nervous system state. And we are trying to avoid it at all costs.
And providers do that too.
Yes.
So I think these things are so different, instead of being like, wow, how can I superimpose my skills? Right, to something that I'm unfamiliar with and that I have a fear of because I'm afraid it will be different. And so like, I spent the first 10 years of my career in jails and prisons and halfway houses. And I just was like, how is that going to transition now into the community and working with some of those things? And when I started to think about how I was going to work with couples, I was like, that really wasn't something I did in jails and prisons. But I was like, but if I think about the fact that I sat in a room with gang members who legitimately wanted to kill each other, and I could hold space for that, I think I can handle space for a couple that's angry and resentful and is trying to find the vulnerability with each other again, right? So I was able to start to think about, our skills really aren't different and our disorders really aren't different. We think that our specialty niches, they are, but when we broaden it to be like, well, how are they the same?
Yes.
I really, when you should, the questions came in, I was like, okay, well, I actually don't view them drastically different. I think how we treat them can be different, but like when you're talking about that moral space, my whole hypothesis is that what's unique about the 10% that struggle and the other 90% that don't is a moral injury. It's a soul wound. And how do I make sense of that space? How do I deal with what it means to have stepped out of character and be able to highlight for people, we all have, right? We figure out who we are by figuring out who we're not. Is how do you normalize it without pathologizing it so that it's something I did, not what I am? And how do you give beauty? And I think right, there's so much gift in the wound if you will walk through the wound.
Oh my goodness. Yes. So I want to end our conversation, though I don't want to end it, but I want to do a case conceptualization with you because, and this is a conglomeration of many different clients. It's, the name is made up. However, this encapsulates something that I often see. So we're going to discuss the fictional case of Tanya.
Mhm.
So Tanya's a young woman and she has a severe fear of vomiting. This is called a metaphobia. It's very much an it phobia these days. We see it all the time. So Tanya is avoiding places where she thinks she might vomit, places she associates with vomit, and has stopped eating all foods that she sees as contaminated or potentially expired. She begins to use marijuana to get relief and control over her fears of vomiting and the nausea it caused. Before long, she is utilizing cannabis almost every waking hour, and it is the only way she can tame her fear of vomiting and access to her life, according to Tanya. Tanya's parents got her into a residential substance use treatment program, but she gets discharged because of non-compliance. She's so afraid of catching a stomach bug from the other residents that she's not going to any of the groups or participating in treatment. What are your thoughts on how to handle this case?
Sure. I don't think substance use treatment was the right option.
Hmm.
You look at something like cannabis, cannabis actually is an anti-nausea. That is one of its medicinal values.
Mhm.
So if you have a fear that is keeping you from being able to eat, that likely needs to be addressed before you can address if there's a compulsion or not a compulsion around substance use. Because
Mhm.
when I'm reading this or hearing the story, is those things are real for her, whether or not anybody else understands it. And
Mhm.
in a culture that looks at vomiting as getting sick, versus there are lots of cultures who look at vomiting as getting well. We
Mhm.
resent that sickness. Like I'm supposed to, right? It's the total narrative. Hold it, hold it, hold it, versus being like, get it out, purge it. You do not want to keep the things that are making you sick. So I think in that situation, I would start individually in doing work to say, well, what's here, right? Tell me more
Mhm.
about your fears in the vomiting and why contamination is scary, which, right, if I superimpose some of that, right, there's likely a fear of death, right? The
Mhm.
inability. And one of the ways that I would highlight what's happening in an individual session is I was like, you're surviving, right? You're doing that
Mhm.
well. But when you're thinking about meaning and engaging in life, that's living. And those two things can't happen at the same time.
Mhm.
So her motivation to live. And until I know that, then I can't really make a good referral. So it almost sounds like it was like deal with the substance use, right? Because that's the issue, but that's actually the coping mechanism.
Yep.
You don't agree with it, but that is the coping mechanism. So if you look at the substance use, symptoms use, now I'm just making up words. Substance is the symptom rather than the problem, then we can start to say, okay, well, what do we have to do to change that fear narrative to get this
Yes.
symptom coping skill to start to switch? But I don't think anybody would say, I'm going to let you take my only coping skill. And then you just be like, and you just take it, right? Because even in substance use, they kind of consistently give this idea that if you stop using a substance, you're going to be happy. Life is then fairy tales. I'm like, no, it's not. You're not going to be happy. It is still hard and it's scary and living hurts. And, right, in my philosophy, opening up to our pain is the only way that we can get back to our love. And
Mm.
it's our infinite capacity. And so when we restrict our pain, we restrict our love. When we say, I don't want to feel my fear, then we don't realize physiologically, excitement and fear feel exactly the same way. The only difference is the story you have about it. So if you're like, that heartbeat is the butterflies, I'm falling in love, then we're like, okay, it's scary, but I want to do it. And if we're like, that's anxiety and I don't like it and I don't want it, then we miss out on that balance. And so for me, it was a wide jump that didn't actually deal with what was actually driving both behaviors, which really I think is there's a deep rooted fear. And without talking more with her, I wouldn't know what that was.
Mm. Beautiful, beautiful. I honestly, like, I could not agree more with you. Um, if I got this case into my office, I would probably create a good old fashioned fear hierarchy around the metaphobia,
Yeah.
um, because that's one of those types of OCD where there isn't something that much deeper. It really is just the fear of vomiting for a lot of people. Um, and they would rather die than vomit is a thing that they will say to me. So yeah, I would just do what I know there. And then, help the treatment for OCD is exposure response prevention, but the response prevention piece is helping her not utilize cannabis every time she's feeling anxious.
Yeah.
And so that I would collaborate
Mhm.
with an addictions professional like you to know what I don't know around how to slowly reduce.
Well, but I I actually think you do know,
Mm,
right? Is like when you're saying it's a subtle exposure that you're going to help her understand the intention behind the use, right? Like, so I'm
mm,
using because I just like it.
mhm,
That this is what I do a lot of times with people with substances where I'll be like that are on this slippery slope. So they're not yet diagnosable, but they're relying on substances and they're using it to cope with life. That's when you're on a super slippery slope because they
mm,
work. Is it's like if you can sit down and say, I really like that glass of wine and I just want to enjoy it, then I'm like, then do it. If you're saying, I'm drinking this because I don't want to have to deal with life, you might not want to use it in that moment. But what we're both trying to do, it sounds like, is we're trying to get them to learn how to manage the experience of fear and emotional discomfort in a way that then they could meet their goals. If that means not
right.
using cannabis, if that means not being afraid of vomiting, if it means how those things come together, that it
Mhm,
might not be stop using substances. It might be, well, what's your intention when you use it?
mhm,
If you're really feeling nauseous and again can't manage that fear, is that an acceptable occasional way to manage it, or is it fueling the fear? And I think that's where we have to really do the work to explore further and to
mhm,
trust the clients actually in having
mhm,
the answers that they seek. That as
mhm,
clinicians we are just trying to help them find the answers in themselves.
mhm.
And I really I always find it fascinating when providers, which is our fear and how we've been taught, it's out of our scope of practice. And it's like,
Yeah.
is it though, right? As a licensed clinician, we get to work with mental health,
Mhm,
right? Now, if you're saying I'm doing substance specific work, then yeah, you want to have a scope of practice. But if you're saying I'm actually exploring how substances have a unique connection into OCD, that is a niche that I'm not sure, like we recognize it, but nobody's stepping into it and being like, I'm going to try something different.
Yep.
And
Yep.
isn't that what every model as it evolves is how we get better at saying we suffer from this terminal case of terminal uniqueness, that everything is
Yes.
unique in a way
Right.
that it's like, I don't anymore. And I don't live in a world of, I'm not big any longer in the misery management side of things or diagnosis. I'm more just like, what do you want in your life differently? Right.
Mm,
And how can I support in doing that? And from that really existential way of like, it's grace. Every one of
mm,
us is doing the best that we know how.
hmm,
And so if I trust that, right? Like I don't see how your world actually is different from mine. It's just
mm,
a different coping tool.
hmm. Amazing. That is where I want to end because that is such a such an incredibly encapsulated fine point on a conversation that I think needs to continue. It was such a pleasure having you on, Thea. I hope this is the first of many. I know that I have learned a lot today. And what I really appreciate about you is that you're thinking about the whole person. That is like it's such an important aspect of modern mental health medicine and treatment that we don't silo ourselves off just in the brain or just in the emotional centers.
Yeah.
Thank you so much for joining me today, Thea.
Thank you.